Welcome you all in this the last session of this conference. This is Anterior segment Potpourri. I am convener Dr. Nagendra Prasad, and I request Dr. Sushmita Sahaj, sir, madam, for his presentation in advanced pharmacotherapy and its application in anterior segment disorder. We have with us Dr. Upesh Singh is over here. So you will be waiting for the others to come. Start, please.
Thank you, Dr. Prasad. Good morning to all. So I will be speaking on a small part of the anterior segment, advancement in the anterior segment pharmacotherapy. And it is, I'm going to talk more on the advancements and about our work in the management of fungal keratitis. Okay, so this talk I'll cover the current drug and adjuvant therapies and the newer research, our experience. So as you all know, the first line of drug for fungal keratitis is natamycin, which is belongs to the choline group and binds to ergosterol on fungal plasma membrane. It is commercially available as 5% suspension and is the drug of choice for filamentous fungi. However, according to the MUT1 trial, topical natamycin was found to be superior to topical Boriconazole for filamentous fungi, and a major difference was noted if the keratitis was due to fusarium. Also, improved vision-related quality of life is also noted in patients with fungal ulcer who received natamycin. And patients given natamycin had lower risk of corneal perforation. Coming to Boriconazole, which is a drug belonging to the azole group, it blocks fungal membrane synthesis by inhibiting cytochrome P450, and it needs to be reconstituted to 1% solution from the lyophilized powder. It works better against aspergillus as compared to fusarium. In the MUT1 trial, they have concluded saying that monotherapy is not recommended for fungal keratitis due to filamentous fungi. And the biggest problem with Boriconazole is that even though it shows very low MIC levels in vitro studies, the in vivo results are not consistent. Also, systemic side effects are there with Boriconazole therapy. And Boriconazole has also been used systemically as oral at 400 mg BG on the first day and 200 mg BD for the next days. IV injection has also been recommended. According to the MUT2 trial, there is no benefit of adding oral Boriconazole to topical antifungals in the treatment of severe smear-positive filamentous fungi. The same conclusion could be drawn from another study evaluating the corneal buttons from patients undergoing therapeutic PK, the primary cause for perforation being inflammation. But adjuvant oral Boriconazole therapy showed decreased rate of perforation and or need of therapeutic PK in eyes if the keratitis was due to fusarium. Its side effect, it's hepatotoxicity. Coming to the other group, which is the amphotericin B, which is a choline drug which binds to ergosterol on fungal cell membrane and alters fungal cell permeability. It is the drug of choice for candida infection, second line for aspergillus, and it is to be reconstituted to 0.15% drops. Liposomal amphotericin B is also available, though it's a little expensive, but it can avoid the renal toxicity of the routine amphotericin B. Other azole drugs which have been used, there are a couple of reports, or anecdotal reports actually, which include iconazole, fluconazole, ketoconazole, and itaconazole. Ketoconazole and itaconazole, however, are routinely used as systemic medication as an adjuvant therapy. Newer agents include triazoles like posaconazole and ravuconazole, and echinocandins like caspofungin, micafungin, and idursulfungin. Okay, the reports again in fungal keratitis treatment is again anecdotal, and also the biggest problem with these drugs possibly is also the cost. And so to summarize the current drug therapy for medical management of fungal keratitis, we need to first do a corneal scraping and microbiology. And if it is an yeast, we start with 1% Boriconazole eye drops. If it is a filamentous fungi, we start with 5% natamycin drops. And based on the culture report, if it is fusarium, you have to add oral Boriconazole because that has adjuvant better effect. And if it is aspergillus, we can add topical Boriconazole or amphotericin B. And in case of no response to either of this, the last resort, of course, is a therapeutic keratoplasty. Now, antifungal injections are also getting popular more and more. So both Boriconazole as well as amphotericin B are being used as interstromal or intracameral injections. The concentrations are described here. However, this study published again from South India said that there is no added benefit of intrastromal voriconazole in eyes receiving topical 5% netamycin. In a recent report from again from RP Center, they have shown good efficacy to intrastromal netamycin formulation in cyclodextrin. When it is injected into the stroma, it causes good reduction in the fungal keratitis thing. So as you can understand, there is an unmet need here, as netamycin has multiple drawbacks. It is fungistatic, it is poor penetration across corneal epithelium, and high tissue binding leading to poor bioavailability. It is insoluble in water and used only as topical suspension and cannot be administered by any other route. And compared to bacterial ulcers, fungal ulcers are more difficult to treat with poorer outcomes. So we chose to work on peptides, which are an nanomolecule. The cell-penetrating peptides, these are short-chain amino acids, which act as can carry a cargo across the cell membrane without causing that disruption. It is usually positively charged non-viral drug delivery system, which can be both energy dependent or independent. It is non-toxic and biocompatible, and exact mechanism of action is not known. So we created a conjugate of cell-penetrating peptide with netamycin, which we called as the TAT2NAT, and following conjugation with the TAT2, netamycin, which is otherwise not soluble in water, became soluble in water. Now here are the in vitro results. So here these images show the human corneal epithelial cell lines. As you can see in the last image on the lower panel, you can see that excellent internalization of the TAT2 netamycin into the human corneal epithelial cells in vitro, which indicates that the TAT2 has been able to carry the netamycin into the corneal epithelial cells, whereas in the only netamycin group, the netamycin has not been able to penetrate into the corneal epithelium. The similar result was also seen when we exposed TAT2-NAT to fungal filaments. These are the Fusarium solani filaments in vitro, and you can see here there is significant fluorescence coming out of the fungal filaments in the last two images down. There is no penetration of netamycin into the fungal filaments. And here, when we expose the human Fusarium infected human corneal epithelial cells to the TAT2 netamycin, we could see complete inhibition of the fungal filaments, as is noted in the last image down. So after having gotten such good, excellent results in the in vitro study, we planned the animal study. So the first purpose of that was to establish a mice model of Fusarium species keratitis, followed by evaluation for the antifungal efficacy, and subsequently to look for the drug permeability across the intact corneal epithelium in the rabbit eyes. So this is the mouse model that we created. These are mice which are first immunosuppressed, and then the right cornea is scored using a 26 gauge needle, and the fungal suspension is applied on the cornea, and the eyelids are rubbed for a few seconds. And we tried 3 different concentrations of fungal spores to figure out which would be the appropriate dosage for creating the keratitis. And then the keratitis was graded after 3 days of induction based on this slit lamp grading. The grades 2, 3, and 4 are the eyes with the proper fungal keratitis and infiltrates. So when we evaluated the 3 different concentrations of colony forming units, we found that 10 to the power 5 CFU per 5 microliter was the most effective in creating keratitis. So this particular concentration was used for further studies. So these are the various slit lamp grade of keratitis that were used, and as you can see here, grade 2, 3, and 4 show significant keratitis, and these grades were included in the further study. So then after induction of the keratitis, the right eye received various drug groups, various drugs as per the grouping, and the topical formulation, drug formulation was applied 6 times for 3 days, 10 times for 3 days, and then 6 times for another 3 days. So at the end of 6 days of treatment, the slit lamp grading was done and animal was sacrificed. And so this is a bar graph which shows the reduction which evaluated the efficacy of the treatment with the drugs. And as you can see here in the TAT2-NAT group, there is significant improvement in the grading of the keratitis and improvement in the clinical scores as compared to netamycin alone. The peptide alone also, TAT2 also showed some amount of antifungal efficacy. And when it comes to complete resolution of the keratitis, we can see that only 12.5% animals in the natamycin group had complete resolution of keratitis, while in the TAT2 natamycin group, in the 200 micromolar, it was 37.5%, and in the 100 micromolar, it was about 45%. And these are some of the images to demonstrate the efficacy. You can see the top panel is the pre-treatment images, and the lower panel is the post-treatment images. You can see good results with the TAT2 natamycin, both in 200 as well as 100 micromolar concentration. Next was to prove that being peptide conjugated natamycin, the peptide, whether the peptide is able to carry the natamycin across the corneal epithelium. So these rabbits were taken. The right corneal epithelium was debrided. The left corneal epithelium was left normal. The drug was applied 4 applications, once in every 15 minutes, and at the end of 1 hour, the concentration of the drugs were evaluated both in the cornea, aqueous humor, as well as in the vitreous. And the left chart is the eye, the left eye, which has the intact epithelium. Here you can see, compared to natamycin, the TAT2 penetration is significantly higher. TAT2 natamycin penetration is significantly higher, both in the cornea as well as in the aqueous humor. The same thing is noted in the right eye, where the epithelium was debrided. Again, though natamycin penetration improved following removal of the epithelium, but there was still a significant difference in the concentration of the TAT2 nat as compared to natamycin, both in cornea as well as in the aqueous humor. And we also exposed, this is another experiment which we did, we exposed the fungal fusarium spores to the drugs. As you can see in the third panel line of images, you can see significant shrinking and damage to the fungal spores with TAT2 natamycin as compared to natamycin alone. So to summarize, TAT2 natamycin showed better antifungal efficacy as compared to natamycin alone in our murine model. The peptide alone also showed significant antifungal activity. Also, higher penetration of TAT2 nat was noted in the cornea and aqueous humor in vivo as compared to natamycin alone, and this difference was statistically significant. And thus, to conclude, TAT2 CPP conjugated natamycin appears to be a promising strategy for delivery of natamycin with increased penetration and effective antifungal activity. These are the 2 papers that we published, and I'd like to conclude by acknowledging my team with whom we have been working, essentially from IIT Delhi and the National Institute of Biological, and also Dr. Pujari from the Breach Candy Hospital. Thank you very much for the opportunity.
Thanks, Dr. Susmita. Now I call upon Dr. Bhupesh for keratoplasty with cataract in different situations. We may take one question only by the time in between his preparation. If any question, please.
Any questions? Yes, please. Yeah, we are trying to do the technology transfer, so we are in talks with the industry. So this the whole work was done without any participation of the industry. It is purely an academic thing. So now we are going to the industry and talking to them, but then there are a lot of regulations and stuff which are there. So might take some time, but we are on it.
So it acts as a vehicle for the introduction.
So after the nice talk by Dr. Sushmita, I'll be talking on a different subject. It is keratoplasty with cataract, different situations. So I have no financial disclosures. So the triple procedure, that is combined keratoplasty with cataract extraction and intraocular lens implantation, is a well-established and effective surgical treatment for patients with both corneal and lenticular opacities. It was first described by Taylor in 1976, and since then the procedure has evolved considerably. If we talk about the advantages of triple procedures, triple procedure helps in prompt visual rehabilitation, protection of transplanted endothelium, superior functional results following triple procedure, no need for second surgery for visual rehabilitation, and it is also economical. Although there are certain challenges involved in this procedure, like difficult surgical technique, cortical removal is especially challenging in such cases. High posterior vitreous pressure is the main thing that causes all the trouble in open sky cataract surgery. The problem in intraocular lens power calculation, because the cornea is very bad, so you don't get the exact power in most of the time, so you have to take the other eye's values. And intraocular lens implantation due to high vitreous pressure is challenging sometimes. And after all the efforts, sometimes results are unexpected. So the indications for cataract surgery with penetrating keratoplasty is if the cataract is visually significant, or there is corneal perforation with lens plastering to the cornea, there is a high vitreous upthrust, ruptured anterior capsule, subluxated cataracts, and intraoperative lens damage. So this is a study done by Dr. Sridhar et al. From LVPI, and he has shown that the main indication for cataract surgery is corneal scarring with cataract in 69 cases. And if we talk about the problems occurred during the surgeries, vitreous upthrust in 7 cases was noted and PCR in 3 cases. And in the post-operative period, the main concern was increased IOP in 19 patients and increased AC reaction in 25 cases. Although he concluded that this is a safe and surgical procedure with good graft clarity and reasonable visual recovery. This is another study in which similar result has been shown. So if we talk about pre-operative preparation for such cases, we have to look for the lens status, how severe is the cataract, any sign of peripheral anti-synechiae, look for phacodonesis or lens subluxation, check the IOL power. If involved eye has a bad cornea, then IOL power can be calculated in the other eye after checking the axial length. So intravenous injection mannitol is mandatory for all triple procedures, and the standard dose is 3 to 5 milligram per kg body weight. Alternatively, tablet acetazolamide 250 milligram, 2 stats before the surgery can be given. Good ocular massage is must for these cases to reduce the posterior vitreous upthrust after the local anesthesia. Although in perforated cornea, we should not massage and give the block in steps, in multiple steps. And pupillary dilatation with mydriatic should be tried in all cases. So this is one of the case in which you can see there is a dense infiltrate with the central corneal perforation. So Fleringer ring is another very useful device for all open sky surgeries, especially if you're going to combine with cataract surgery or in therapeutic cases. So Fleringer ring is applied in this case also. You can secure it at 4 points with Vicryl sutures. Then after the trephination, just see the adhesion. The cornea is very edematous, and as soon as I removed the cornea, the lens has popped up because of the ruptured capsule due to the infection. And simply you have to lift the lens. So it's always better not to put lens in cases of therapeutic keratoplasties or if the capsule is not very clear, because in the bag implantation is not possible in such cases. So irrigation aspiration cannula usually don't work very well in open sky surgeries. Gently you have to keep injecting saline, loosen the cortex, and Simcoe cannula works very well in all open sky cataract surgeries. And then measure the graft and put the new cornea back and wait for the recovery, and then go for secondary IOL. And after completing the surgery, the Fleringer ring is removed. So this is another surgery with the corneal scar, not that bad, with cataract surgery. And combined triple procedure is planned for this case. So rhexis is done. I prefer cystostome in all these cases. The chances of rhexis extension in these cases are very high. So we have to be very careful while performing rhexis. And then gentle hydrodissection is done and lens is popped up. Simcoe cannula has been used. The main problem that I faced with the bimanual irrigation aspiration is the reflex of water so much that you cannot see where the cortex is. So Simcoe works well. Hard PMA lens usually works very well in all cases of triple procedure because they're very hard and they stay beneath the capsular margin. Single piece IOLs are sometimes difficult to place in the bag. And then surgery is done. Next case. So another challenging situation in triple procedure is a small pupil because most of these cases are inflammatory eyes, and so there is a chronic inflammation. Many times atrophic iris patches, iris sphincter damage, posterior synechiae, peripheral synechiae. So performing rhexis in these situations are a challenge. So these two devices I regularly use in all my cases. First is a Malugin ring, other is a Zepto, and these works very well in open sky cataract surgery. So Zepto, most of us know about Zepto. Zepto is a precision pulse capsulotomy, and this makes 5.25 millimeter rhexis in a standardized fashion with a flexible suction adapter in which a nitinol ring is placed. The rhexis is always circular, fixed size, repeatable in all cases. In comparison to femtosecond laser, Zepto rhexis is stronger and economical for patients as well as for the hospital. So this is another case of dense corneal scar with vascularization. So trephination is done, and you can see the iris pupil is not dilating. So I tried viscodilatation also, but it didn't help. And with Zepto, you can gently sweep in beneath the iris without damaging the sphincter. The cup of Zepto is very soft; it don't damage the capsule or the iris. So gently you have to tuck in, and once you are sure that it is beneath the iris and in the center, then gently press the button, and it will take 1 second to do the rhexis for you. It's done. And then lens is placed and graft is attached. So I published this technique also, and this is working very well in my hands. Another technique is a pupil expander. So normally we use this device in cataract patients, but it also works very well in open sky cataract surgery. It provides a stable interchamber because it presses the iris. So vitreous upthrust is also reduced with this device, and you get the good rhexis in all cases. So how to use this device? After removal of host cornea, Malugin ring is loaded into the injector and engaged into distal iris portion first, then subsequent lateral sides of the iris was engaged, and the last proximal iris is engaged. After confirming all the engagement of all the scrolls are secured behind the iris, CCC is performed. So this is a surgery. You can see I tried dilatation, but it didn't help, and then Malugin is placed. Many times cataract is so bulky that it's not possible to take it out from 2 millimeter. Just see the bulkiness of cataract. It's black cataract, and all the maneuvers are easy, removing the epinucleus plate, cortex, putting the lens behind the rhexis, and once everything is done, this is removed. So this technique was found safe and effective in all cases that I'm doing from last 3-4 years. Adequate pupillary dilatation was maintained throughout the procedure. No intraoperative or postoperative complication was seen in any of the cases done with this technique. If you have to combine cataract surgery with therapeutic keratoplasty, it's ideal to avoid cataract surgery along with therapeutic keratoplasty because chances of going infection into the posterior segment and rate of postoperative inflammation is very high in all these cases. Increased IOP postoperatively, and PC, if there's a PC rent by any chance, risk of endophthalmitis is also there. And now people are doing cataract surgery with DSEC. So basically this is a new triple surgery. Most common indication is fugue endothelial dystrophy. Cataract surgery is performed before DSEC lenticular insertion, and we should avoid PC rupture intraoperatively because that will affect the lenticular attachment. So in conclusion, triple procedure is good and safe surgical options if all the preoperative and intraoperative precautions are well taken. Zepto and Malugin ring are useful devices in cases of a small pupil in open sky cataract surgery. Dilatation provided by these devices helps in formation of capsular rhexis, extraction of cataract lens, and IOL placement in the back. Thank you.
Thank you, Bhupesh, for an excellent talk, and
Thank
it is
you.
very
Thank you.
elegant videos, and you have covered the entire spectrum very elegantly. Thank you so much.
you,
And
ma'am.
if there are any
Thank you.
questions, one question we can take while our next speaker loads his presentation. And our next speaker, I would like to invite Dr. Sudesh Arya for his talk on AMG in ocular surface disorders. Dr. Arya, please. Any questions for Dr. Bhupesh? Okay, Bhupesh, I had one question. So what about the anesthesia? Because once we open globe, it's always a very difficult situation for the surgeon. And surgeon is always having palpitations. So do you prefer GA or prefer LA, or what would be your comment on that?
We always do in LA, although GA is ideal for all these PK patients, but sometimes finances and all those things you have to look
Yes,
after.
logistics.
Definitely pediatric has to be in GA, but adults we always go for local only.
Thank you.
Yeah.
Good afternoon, everyone. So I'm going to speak on this topic of amniotic membrane graft in ocular surface disorders. So as we know, this human amniotic membrane is the innermost layer of placental membranes. D. Roth, first of all, described these placental membranes to repair conjunctival defects. There was low success due to highly immunogenic chorionic rejection. Then Sosby used chemically preserved dry amniotic membrane called as amnioplastin for the treatment of ocular burns. And Kim and Seng, they reintroduced the use of amniotic membrane in ophthalmology. So we know anatomy of the amniotic membrane. So there are amniotic membrane and the fetus are derived from the same cellular origin. So this amniotic membrane, it supports, nourishes and protects fetus during 9 months of gestation. The basement membrane of the amniotic membrane resembles that of conjunctiva and provides substrate for growth of epithelial progenitor cells. This facilitates epitheliation for persistent epithelial defects with stromal ulceration. It promotes goblet and non-goblet cell differentiation of the conjunctival epithelium. This amniotic membrane stroma contains many protease inhibitors which help in reducing the stromal inflammation after amniotic membrane transplant and also decreases corneal neovascularization. So we can have so many clinical effects because of amniotic membrane, like anti-adhesive effect, bacteriostatic, wound protection, epithelialization, and there is a lack of immunogenicity, so that's why it is well taken. So this is how we prepare in our department this amniotic membrane. Video not running. Can you run this video, please? अलग से वीडियो इसमें दिखा दो मिनिमाइज I'm sorry, it was running in the preview room, I don't know. VLC
Would you like to reload again, sir? Then we can have the next talk.
I think run with VLC, yeah.
Yeah.
Sorry for delay. So basically, there is a modified Delbaco medium, that is a medium that is used. So then we have this millipore filter. Then after taking placenta from the normal cesarean section, so that is very important. Then all the clots, they are removed. Then this, you can see placental membrane, they are being separated. And this tray then is containing this tobacco medium. Then after removing, it's very simple to remove. Then we put in this tray where a lot of antibiotics, antifungal drugs as recommended. So they are put, and then these are thoroughly washed, and all the clots, they are thoroughly removed. Then on the millipore filter, we can just attach them, and then we can cut various size, then put in the this tobacco medium where we are preserving at -80 degrees centigrade in the deep freezer. So then you can use like from one patient you can use for 6 months. So many patients, like 40-50 patients, you can use this by one per patient. So that's very easy to prepare. So and very cost effective also. So what are the various clinical application for this amniotic membrane? So like there are so many endless condition where you can use it, but few condition which I'm going to highlight, like pterygium, then pseudo-pterygium, then various wound, blebic in glaucoma surgery, scleral melt, lid reconstruction, and orbital reconstruction, and simple limbal epithelial transplant as well. So like there are few specimen patient where we used them. Like this was a child, 10-year-old, having a firecracker injury. Because of that, he developed extensive symblepharon. So this symblepharon was removed. The ocular motility was restricted. So after this removal and putting the amniotic membrane, you can see the motility also well restored, and it was very deep fornix also. Similarly, in symblepharon, all these patients, sometimes they have a lot of symblepharon due to chemical injury or some other conditions. So there you can just remove them, and then you can put either conjunctival graft or maybe amniotic membrane also. When sometimes there is a bilateral chemical injuries, their conjunctiva will not be available. So in those conditions, this amniotic membrane is a very useful thing which can help. So in these patients, it is going to help a lot when we are not able to have conjunctiva from other patient. Similarly, pseudo-pterygium formed after extensive other conditions where you will have this membrane formation. So once these are removed, then you can replace them with amniotic membrane. So there is a one condition where there is a sometime corneal fistula formed. So there is a perforation, then that perforation gets epithelialized, and then it doesn't heal whatever you do. So in these conditions, just freshen up the edges of the perforation and then put amniotic membrane multi-layered graft. So if you put that, then definitely it will seal. Similarly, persistent epithelial defect due to any cause, like post-PK patient, many patients they develop, then there are viral keratitis. In those conditions also many times this defect doesn't heal at all. So in these conditions, if you apply amniotic membrane, the epithelium defect, it heals very nicely. So it's a very good indication where any epithelial defect which is not healing, just apply amniotic membrane, it will definitely heal. Then thermal injury also, sometimes they come with superficial thermal ones with a lot of, you can say, epithelial defect only. So in these conditions, if you put this amniotic membrane and give topical steroid, it will nicely heal without causing any vasculation of the cornea. Stevens-Johnson syndrome, again, is a condition where there is a lot of scarring of the conjunctiva with symblepharon, dry eye, so many limbal stem cell deficiency, this lid margin deformities. In these conditions, it is very important that we have to take care of local ocular inflammation. So what we can do, we can just put this amniotic membrane and give topical steroid. So you'll have nice ocular surface because of amniotic membrane. And then this complication of symblepharon, they will not happen in these patients. So sometimes very rare condition, like we had one patient with porphyria cutaneous tarda, where there was necrotizing scleritis and keratolysis also happening. So in these patients, you can't do immediately keratoplasty. So just you have to give some tectonic support. So multi-layered amniotic membrane, if you can put in the immediate phase. Later on, you can do therapeutic graft. So this patient also helped. And there are scleral melts also sometimes. So these also can be taken care by multi-layered graft. So it is a just transient management. Later on, you will require optical keratoplasty as well. SLET is a very common condition nowadays where due to limbal stem cell deficiency, so it's very good surgery. So where Dr. Sangwan described, so this is a very good technique where you need amniotic membrane and it gives very good results. So you can see this patient having this chemical injury. After that SLET, the cornea is absolutely clear. So there are a few other conditions where there is a corneal thinning. So sometimes amniotic membrane may help in these conditions where you're not able to do graft immediately. So even DELC also, in combination with amniotic membrane graft, it definitely helps in certain conditions like Moran ulcer, then certain corneal opacities, viral keratitis. So you can mix DELC with amniotic membrane, so then healing will be very fast and very easy. So of course there are few limitations also, like if there is a total limbal stem cell deficiency, then it will not help. Severe aqueous tear deficiency, then diffuse keratinization, severe neurotrophic keratopathies, stromal ischemia. In these conditions, it may not help that much. So to conclude, this selective use of amniotic membrane it can show encouraging results in various ocular surface disorders, and it can restore stable and non-inflamed ocular surface in these situations. And in moderate to severe ocular surface disorder, amniotic membrane in combination with limbal stem cell or transplant or SLET can give excellent results in restoring near normal ocular surface. Thank you very much.
Thank you, sir. Thank you for a wonderful talk. I just maybe the next who's the next speaker?
Yeah, so request Dr. Ritu Arora for her talk, which is how to manage post-op refractive surprise after cataract surgery.
That is Mohit's.
No, but it's been, that's it's written that one. Sorry, dry eye therapy, role and results of IPL. Sorry about that. Our experience. Yeah.
So I have a question for Dr. Arya. Sir, you are using very nicely the wet amniotic membrane. So what is the difference you found between dry and wet amniotic membrane? Thank you, sir.
Good afternoon, and at the outset I would like to thank AIOS for giving me this opportunity. My talk today is on dry eye management and my experience with IPL. As we know, dry eye is a really hot topic these days. There's a growing prevalence, and I think this connector is loose, sir. Kindly change it. I think put another one.
कनेक्टर तो ठीक है, स्क्रीन पे आ रहा है.
So, So dry eye is a really hot topic. There's a growing prevalence, and almost 20 to 30% of our OPD patients, if you see them, do have a dry eye problem or they complain of dry eye symptoms. Most of these patients are pretty unhappy, and it affects the quality of their life. You often go doctor hopping. They are underdiagnosed, and they're often dismissed as khujli pani patients. It's frustrating for the doctor too, because it's a multifactorial causation, and they are chronic patients who are difficult to satisfy. Now we know the pathophysiology of dry eye. The Dew's classification has shown us that evaporative dry eye is the major cause, and meibomian gland dysfunction is a very important part of this, along with the environmental factors, hormonal changes, dysfunction of the meibomian glands, along with changes in the meibum. There's inflammation, there's obstruction of the glands, and all this leads to a chronic issue with duct obstruction, inflammation, and keratinization. So how do we diagnose dry eye? Of course, we need to do a detailed examination. The first thing is to do a dry eye questionnaire, do a slit lamp examination, look at the morphology of the glands, do a gland expression, do the tear breakup time, Schirmer's and corneal staining. But now we have a very useful tool, which is the ocular surface analyzer, and this at one point, it can give you a very detailed evaluation of the ocular surface. So we've been using this now for almost 2 years, and it gives a very nice and easy to do dry eye workup. You get the non-invasive tear breakup time. You get the mebography, where you can see the dropout of the meibomian glands. You can see the tear meniscus height along with the lipid layer evaluation. And more important than anything, it gives a printout which is easy to explain to the patient. Because when you're seeing dry eye, you're seeing the meibomian gland problems, it's difficult to explain to the patient that this is a chronic problem. But when you show them the printout and you actually show, where the issue is, they are much more amenable to treatment and follow-up. So now there are many management modalities for MGD. Of course, a lifestyle and environmental modification, reduction in the digital screen time, sensitizing the patient about their blink rate. All of that needs to be done, along with warm compress and massage, giving the tear substitutes, anti-inflammatory medications, immune modulators, and all. So we have so many things, but at the end of the day, many of the patients still do not get relief, and many of these traditional therapies are inadequate. So what do? We feel often we feel helpless how to help these patients. So now the intense pulse light therapy is our new kid on the block, and it has been used in dermatology, in fact, since '94. And it was Toyos et al. Who first reported it, incidentally, the benefit in dry eye in 2002. And since then, there have been a large number of publications, and its use in MGD has been well documented now. The mode of action is it's a polychromatic light with a wavelength of 500 to 1200 nanometers. It works on the principle of photothermolysis. The light is directed to the skin. It gets absorbed by the chromophores, such as the melanin, hemoglobin, and all. It develops heat, and this causes the blood vessel ablation. Baumler et al., they demonstrated that even a single pulse of IPL, it helps to coagulate the large blood vessels. And it is these blood vessels actually which are releasing the inflammatory modulators, which are triggering the MGD. And this is how, the basic concept of IPL is based on this. It also causes a fluidification of the mebum. It causes photomodulation, demodex eradication. It has an anti-inflammatory effect. So it's a multi-mode action, actually. Along with this, you have the low-level light therapy, which utilizes a longer wavelength, which is the red light. And this causes a photobiomodulation, where it stimulates the meibomian glands, both in the upper and lower eyelids. It increases the mebum production, and thus, consequently, it improves the tear breakup time. So we have the eyelight. It has a dual advantage because it has both the IPL, the intense pulse light therapy, as well as the low-level light therapy. So we give most of our patients, we give them these synergistically, both the technologies are used. And the procedure itself is very simple. Our optometrists are trained to do it. The intensity depends on the patient's skin type. So first we check for the skin color. It's an automated mode in the machine. And based on the score, the amount of light given is modulated. An eye shield is placed to protect the iris. And 5 flashes of light are given along the lower lid till the temple. And this is then followed by the mask therapy. After that, we do a manual expression on the slit lamp, and you can actually see the mebum flowing out. So our experience has been, over the last 20 months, we've done about 150 patients, of mostly mild to moderate. 50% of the patients improved with just a single sitting, and about 30% required 2 sittings, and very few needed more than 3 sittings. Some of the chronic patients have required a repeat procedure after 6 months. Normally, we give a gap of 3 to 4 weeks between 2 sittings. And most of the patients, they show within 2 to 3 weeks, they start showing improvement in the symptoms and reduction in the medications which are required. And on a long-term basis, it's found that the tear breakup time and the ocular surface staining also shows improvement. Side effects are almost negligible. You have to protect the iris. We use protective glasses because the iris can absorb the light, leading to a little mild iritis. And very transient effects on the skin, like some tingling sensation or erythema, and very rarely you get some pigmentation or blistering. Soothing gels can be advised, and you should advise the patient to avoid exposure to sunlight. Of course, in very darkly pigmented patients, we have to be cautious. So my take-home message is that dry eye is almost a pandemic now with increased digital screen usage. And in fact, we've seen a lot of children, school kids who have been coming to us with meibomian gland dysfunction. And a timely diagnosis and treatment is important because once it goes into the chronic stage, the treatment becomes very difficult. The conventional therapies are only giving supplements from outside, but we need to treat the actual cause of dry eye, which is from the meibomian glands itself. And the newer modalities like IPL and vector thermal pulse are useful, but I have preferred IPL because I feel it addresses the main issue of inflammation and the meibomian glands, whereas vector pulse is just a expression of the meibum. So this has been very safe, effective, and repeatable. And of course, a longer follow-up would be required to see the duration of efficacy. Thank you.
Thank you, Dr. Arora. That was a lovely talk. I just wanted to ask you, you've said that in certain patients you have had to repeat the sittings. So how long do you normally wait before you do the next sitting?
See, normally we would, at the outset, we tell them that you need 2 to 3 sittings. Now, most of them we found that even with a single sitting, they become so comfortable that it's difficult to tell them to, go for the second.
Yes.
And I have had one patient in whom, she asked me after 6 months that, doctor, I would like to repeat it.
Okay.
She was actually very happy and she said, and now I'm getting a slight irritation and all.
Okay.
And she asked for it. And actually, there have been only 4 patients in whom we've had to repeat it after 6 months. I would wait at least for 6 to 8 months before giving a 4th sitting.
Thank you so much, ma'am.
Thank
you. Yeah, so next speaker, Dr. Yes, please. Meanwhile, Dr. Mohak Shah is our next speaker. He's going to talk on how to manage post-op refractive surprise after cataract surgery. While he's loading the presentation, sir, please go ahead.
How much does it improve? Yeah, definitely. See,
Any percentage like 20% increase, 30% increase in the summer's time or the clear breakup time after this?
see, we have personally not done our own, study as such. It's more symptomatic that we've done. But if you look at literature, there are vast number of studies. That's what I showed you. There is been I have the thing, I can show it to you. There have been studies which have shown that all the parameters.
What you said that symptomatically they improve, that means?
No, that is symptomatically that my experience. But if you see the literature, there are a number of studies in literature and there are which have shown that the tear breakup time.
It must have improved on the tear breakup time also.
Yes, all the parameters have improved. Yeah.
If you can collect the data about it, then it will be great.
Yeah, thank you.
First of all, I'd like to thank Dr. Pathophysiology sir for giving me this opportunity. Okay, so we have mirror. Okay, so it's still not coming properly. Hmm?
We'll do a quick roll call in the meantime.
Yeah.
Is Dr. Nivian here? Dr. N. Nivian? Dr. Anand? Dr. Anand Parthasarathi? Dr. Kudlu? Dr. K.P. Kudlu? Dr. Sean Chinchole? Dr. Subodh?
Okay,
Please
I'm
carry
ready.
on, yeah.
So you have one of the best industry leading optical biometers, be it like Zeiss IOL Master 700, Landstar, or now Tommy, all based on a swab source. This doesn't matter whether you have these all the beautiful, expensive femtosecond laser platforms and you have used these all the premium IOLs. still diffractive surprises are gonna happen no matter at what institute and which private practice you are working. So why do they occur? First, you need to understand that. The most common factors are the inaccurate IOL power calculation, especially in challenging situations like when you have a long eyes and short eyes, you have a previous history of refractive surgery, there is a pre-existing astigmatism which you have not taken up if you don't have the good topographer, which is not considering the posterior corneal astigmatism. So all these things will require you to undergo for the enhancement surgeries for the refractive surprises. So what do we do? Usually, not all these surprises require the management if the patient is quite tolerable, because there are a lot of patients who are non-demanding. You can still get away by giving them a small correction, an option of monovision. But if not, you have to open this big Pandora box. So what are the options to treat? First of all, I would like to explain based on the duration. Suppose if it is early, then you have to do the limbal relaxing incision, which you can do always manually. And with this now femtosecond laser assessor platform, you can customize it in endless limit possible. The second is the IOL exchange, and in case of there is a wrong axis, you have put your toric IOL, then it requires the IOL rotation. And late, I would like to say the PRK, LASIK and SMILE, and the piggyback IOLs like the Sulcoflex. And based on where we perform the surgeries, it is divided into the corneal base and the lens base. So let's discuss them one by one. The first is limbal relaxation incision. There is no secret that it's a beautiful procedure if performed well. So basically, up to 1.5 diopter of the astigmatism, it works very well, even with the manual ones. But for this, I will advise you need to have the good topographer, which will show you where is the steepest axis, and you just put it over there. Another thing is the IOL exchange, which I think you should reserve for the extreme of the cases where you have the significant, refractive surprise. And even at all you have to perform, it has to be performed within the 3 to 4 weeks max before the capsular fibrosis or adhesions have occurred, because it carries a significant risk of the capsular damage as well as the rend leading to the edema and the RD. Here I'll be quickly showing you one video. The courtesy goes to Dr. Baba. So here, the first thing you have to do, this was performed, I think, after 4 weeks. Patient had history of previous refractive surgery, and there was a refractive surprise. The first thing you have to put the adequate amount of the OVD's viscoelastic substance in front of the lens as well as the back of the lens. So whatever adhesions are there, they will be removed by this visco insertion. So we call it a viscolysis. So once you have done that, you go just behind the lens. You just slightly pull one of the haptic out. And then you take these micro scissors. One can use the MVD, and there is another one is just the normal scissor. The trick here is to cut the lens to up to 90%, or I would say 3/4. You don't have to cut the lens into 2 pieces. Otherwise, it becomes uneasy to control it. So once you have done that, here you can see he has cut the lens up to only 90%. Then you just slightly snatch it out for the same incision. Even you don't have to enlarge the incision. So once the one portion is out, you can always remove the other one very easily. And then you just reload your next lens, just like you are doing a normal cataract surgery, and it's done. What about in case of the toric IOL? Like I mentioned earlier, the main problem is the residual cylinder. That happens because you have failed to consider the posterior corneal astigmatism in calculation. But nowadays, with these advanced calculators like the Barrett's toric calculator and the Heal's RBF calculator, they have taken into the account. And as I told you, if the cylinder is more than 1.5, then you have to take care of their options like LASIK and all. I suppose you have this toric IOL rotation and all, then I would like to quickly show you one site which will help you fix it. This is known as the astigmatismfix.com. Even it is also available on the ASCRS site, where you click on these formulas and you get all those options of the Barrett calculators on. There is one thing is there. Or you just simply go to the astigmatismfix.com over here. You just enter the patient's name, data. Here you have to write, this is where you have to write what was the previous patient's axis. Here you just write the manifest, what is patient's manifest diffraction right now, and what was the IOL plane selected, IOL corneal power, which was selected at that time. It will give you the beautiful options, all the lenses, the industry leading like Alcon, Johnson & Johnson, even Bausch & Lomb, and the Star as well. So once you have done that, just click on the calculate over here. And it will give you this thing. So initially my lens is placed over here, and it is suggesting that it requires a 14 degree of the rotation. So this is how you can work out. Now again, I will tell you the site name is astigmatismfix.com. So what about the correction for the low power? As I told you, the LASIK, PRK and the SMILE, nowadays they take over. So when you perform, that is the most challenging thing. In case of LASIK, I would like to at least wait for 2 to 3 months once your eyes are quiet, or you have at least minimum 2 stable infections. Let us see in different challenging scenarios. Suppose you have the you have inserted the monofocal IOLs, you have the refractive surprise of hyperopia. So usually for the initial 2 to 3 days, it can be due to the retained viscoelastic. But if it is suppose more than one diopter and a bit less than 3 diopter, then LASIK would be my first choice. And if it is more than 3 diopters, then other things take over. In case of myopia, again, as I told you, you can offer the monovision up to 1.5, but it is more than 1.5 and under 6, then you have to go and perform the LASIK. And again, I told you, you have to wait for at least 3 months for everything to get stabilized. What about the profile which we should do if we are correcting this refractive error? So I would say you can use all these premium profiles like the topo-guided nowadays. Contura is the new kid on the block. So you can use the normal one as well as the Contura ones. Cylinder I have already discussed. What about the multifocal IOLs? The only difference thing is you can do just like you are doing with the monofocals, but I would advise you against doing the wavefront guided treatments as well as the Contura, because there is already multifocalities there. By doing this treatment, first of all, it is difficult to acquire the images for the wavefront as well as the Contura. It doesn't work well. And now for the piggyback IOLs like Sulcoflex and all, what are the indications? What are the prerequisites, I would like to say? Now, first of all, you need to have a stable PC IOL with the intact capsular bag, normal or deep anterior chamber, normal endothelial cell count, and no evidence of the pigment dispersion syndrome. And if you have anything like zonules or posterior synechia or reduced endothelial cell count, that's a big no-no. We all know how the Sulcoflex works, so I'm not going into the details. Commercially now they have this monofocal toric, multifocal as well as a trifocal available. I'd like to quickly show you how to calculate the IOL, piggyback IOL power. That is the most challenging thing. The simplest way in case of the hyperopia, you just have to, it is like this spherical equivalent, and this multiply with the 1.5. In case of myopia, spherical equivalent, you multiply with 1.2. There is also the Gill's nomogram which works pretty wonderfully well. And lastly, I have this video, credit goes to Michael Lemon, where he has inserted the trifocal Sulcoflex, which is the new kid on the block. So it's just like a normal, here you can see this is all pre-existing IOL is there. Only thing, the prerequisite, as I told you, the posterior capsule should be intact. So you just like you're performing a normal routine cataract surgery, you just insert the OVDs, then you load the lens, you fill the cartridge with the viscoelastic, just put the lens in a correct orientation, and just slightly, just slowly you inject and see the orientation is correct. There is no rocket science in this, it's pretty simple. Only thing is the calculation of the IO power. So every procedure is plus and minuses, so you have to select them wisely. And this is how I like to go. Suppose I have a refractive surprise error. As I told you, being in-house, we have this in-house examiner as well as the femtosecond platform. LASIK and PRK and SMILE works wonderfully well for us. So if the patient's refractive error is less than 6 in case of myopia, and in hyperopia up to 3, and there is absolutely no all the normal parameters, then we'd like to go ahead with the LASIK. If no, then we'd like to go ahead with either the IOL exchange or the secondary piggyback IOLs. Thank you very much.
Thank you, Dr. Shah. That was brilliant. You covered everything that can be, take all the techniques that can be used to correct refractive surprise. So I would just like to ask you one question. Which possibly is your go-to procedure if you have to choose amongst all of these?
LASIK, ma'am, because I have an inbuilt LASIK as well as the femtosecond platform. So it becomes very easy for me. Because Sulcoflex is also costing me. In LASIK, I have so many patients lined up, so it doesn't cost me anything extra. So just for the financial purpose, I think LASIK because I have the in-house, but suppose if you don't have that, then I think you can do Sulcoflex works pretty well as well for the higher ends.
So basically the bottom line is that possibly a corneal procedure then a intraocular procedure, yeah. So because that has its own disadvantages. Thank you so much. Dr. Nivian, since the remaining speakers are not here, I'd like to invite Dr. Subodh for his talk on understanding EDOF IOLs.
Good afternoon, everybody. At the outset, I would like to thank Chairman Scientific Committee AIS and all the moderators to allow me to speak on understanding EDOF lenses. No financial interest in any of these lenses. Now, what is accommodation? Accommodation is a process by which our eye changes the refractive power so as to get a clear image of an object as the object varies its distance. Now, as our age is young, there is a strong accommodation. As we grow up, in the young age, we lose the accommodation. In the presbyopic age, our accommodation is lost too much. Especially in a cataract patient, we have a presbyopic correction and we lose the accommodation. Now, how to restore the accommodation in pseudophakia? We have got plenty of options. We all are aware of it. First is a monovision, where one eye is kept as myopic, little bit 1 to 1.25, and other eye emetropia, but still it has got its own sets of problem. Multifocal IOLs, we all do it that. It has got its own problems. I will discuss it. Accommodative IOLs, once it was very popular, but nowadays it is not very popular, and we are going to discuss about extended depth focus lenses. The expectations are rising day by day. People are happy with the near vision, distant vision, but still they're asking, what about my intermediate distance? Especially the computer users or the drivers who want to see the picture in the front and also the speedometer. Now, coming to the physics, monofocal lenses, we all know the rays coming from the distance are focused at a single point. We get a distinct single foci and thereby less hollows and less glare. In the multifocal lenses, we have got two distinct foci, so the light intensity get distributed and we get glare and halos and other sort of problems. In the extended depth of focus, we have an elongated focus. So compared to the monofocal, there is little bit of glare, but it is relatively less as compared to the monofocal, multifocal lenses. So what are the demerits of multifocal IOLs? There is a reduced light intensity as the light get distributed for the two foci. There is a reduced contrast sensitivity. There is a perception of rings. Visual aberrations like glare and halos are there, and the subnormal intermediate visual performance is there, and thereby impairing the quality of our life. So in extended depth of focus lenses, we get a clear little bit of near, a little bit of a distance, intermediate and a near. Sometimes we have to add our 1 to 1.25 diopters plus lenses. Now, what are the types of EDOF IOLs? There are the pure EDOF lenses and hybrid EDOF lenses. Pure EDOF lenses are based on the aberration-based EDOF lenses, and the hybrid lenses are based on the basis of diffractive, refractive, or a pseudo non-diffractive beam refractive lenses. Also, they are classified in the base of with the rings and without ring. The first generation is a Technis, wherein the peripheral power is goes on increasing to the center for the near vision, and nowadays more popular is like a Lucidis, which I many times use it. No financial interest. In a Technis, as I said, there is a continuous change in power from periphery to the center, and which gives a better intermediate distance from the center. Now, EDOF by the pseudo non-diffractive beam diffraction, which acts in the Lucidis lenses. Between the diffracting and non-diffracting, there is a pseudo non-diffracting beam. Coming to the physics, as we can see here, there is a diffracting beam coming from the distance. It is focused in the single foci and then it gets diffracted again. In case of a pseudo non-diffractive beam, instead of getting diffracted or from a single point, it is diffracted from an elongated foci and we get an elongated depth focus. And theoretically speaking, in a light coming from a very infinite distance, we get infinite focal points. In a Lucidis, there is an axicon type of a lens where the Gaussian beams are refracted and a basal beam is created, which gives an elongated depth of focus on a principle of Sturm's conoid. These are the pseudo non-diffractive beam as I explained. There is a wafer interference through the spheric surface. A continuous range of light goes and we give a near and intermediate vision. EDOF positioning is also very important. We get a near vision, we get an intermediate distance which is nearer to the near vision and a little bit away from the distance vision. Also, many times if it is positioned towards the hypermetrope size, we get hypermetrope side, we get a distant image, near image, and little bit intermediate vision between the distant and the near. So still there is a gap between the intermediate and a near, or a near and intermediate. But this gap is also bridged by the neuroadaptation method, just like a case of a multifocal lenses. These are the defocus curve which I got in the multifocal lenses, wherein the vertical axis is with a distant vision and the dioptric power changes from 0.5 to 2.5 with a distance of with a diopter of 0.5, 1.5. So we get a distant vision and a near vision, but there is a gap between in a intermediate vision. So a typical type of bihump appearance is appeared in a multifocal lenses, while in a EDOF lenses we get a continuous range of vision from near to the distance, but still there is a drop in a near vision. So we get a near, intermediate and a distant vision. This is a Ocular technology which in which the symphony lenses have come up, where there is a Ocular design profile which it has got a unique design profile with a spacing of a ring, height of a profile, and a shape of a profile, which gives not only the extended depth focus but also a chromaticity, and which gives a good quality of vision. We get a clear image of all the rays, blue, red, and green. Technis Synergy lenses have come up with a combination of diffractive and refractive technology along with the elongated depth focus. They say it's pupil independent, but I still doubt about it. In a nutshell, horizon is yet to come. A natural crystalline lens is a perfect multifocal or a varifocal lenses which God has given to us. Independence from the glasses comes at the cost of unwanted disturbing photic phenomena. High cost continues to be a deterrent for the patient. The near future, we promise post-operative adjustable lenses, but they are in a very experimental stage. Despite achievement of a near perfect post-operative results, the search for a perfect multifocal or idea of lenses continues. Thank you.
Very good presentation and elaborate study and understanding of the multifocal end of lens, Dr. Subodh. And just I wanted to ask, do you modify your oil power while selecting the required power for the?
Yes, sir. When I go for a first eye, like of a dominant eye, I go for a little bit of emetropic side, and for the other eye, I go little bit myopic 0.5 diopter, something like that.
So what is your preferred choice, EDOF lenses or trifocal lenses in comparison? If you have to choose between those two.
I didn't get your question.
EDOF lenses you prefer or trifocal lenses?
No, I prefer EDOF lenses.
EDOF
Sir.
lenses,
Yes, definitely EDOF lenses.
Yes.
I had a question. What kind of patient profile would you consider as an ideal, patient for these lenses?
Yes, ma'am. Definitely, I'll go for just like a multifocal lenses, where the cylindrical diopter is less than 0.75 diopter, and not very myopic patient. I will go more prefer with the hypermetro patients, and similar like that of multifocal lenses, a housewife or say. But still, I are implanted in a male patients also, but they are not complained about the rings or halos as we get in the multifocal lenses.
Thank you so much.
We promise more and deliver less. So that's our principle for that.
Okay.
And it's given really good results. Though I prefer to target emetropia
Yes, sir.
because it leads to a defocus. So my strategy is to target emetropia.
Thank you.
Point noted, ma'am. Thank you.
Thank you.
Okay, thanks. Now I call upon Dr. S.P. Singh, sir. And his topic is iris claw lenses savior for general ophthalmologist. Is Dr. Saurabh Mittal is here? I think this may be the last.
Is Dr. Sean here? Sean Chinchole? Dr. Nivian? Dr. Kudlu? Nobody is there. Anand, I know Anand is not here.
This is going to be the last.
Last, okay. बुला लेंगे इनको एक बार वापस और बंद कर देंगे.
Thank you very much, our chairpersons, for giving opportunity to share my experience and the subject of the retropupillary iris claw lenses. As you know, still IOL implantants in the bag is still the good result in after cataract surgery. But there are certain situations in which there is a this posterior capsule is deficient. Most of the cases, maybe during surgery, complicated surgery, or subluxated lens, extremely subluxated lens, even the congenital condition, Marfan syndrome, where the extreme subluxation is there, or the aphakia with deficient, so many cases. In that case, we have different options. We can't put the IOL in the bag. Then we have to think about the other options. That option maybe, maybe angle supported anterior chamber AC IOL, square fixated lenses, or iris claw lenses. That may be
inclavated either anteriorly or the posteriorly. Now, the posterior retropupillary iris lenses is coming up and gaining a popularity because of that is a very easy procedure, less time consuming, and it had wide scope. That I would like to show directly come to the video. They'll be better if there is a number of cases. So now you can see this is the anterior subluxated lens. In this case, usually you can see it is moving. Usually present mostly it comes in the anterior chamber. Now you can see just slightly rotate it, and you can see that the whole lens is present almost in the anterior chamber. Then slightly rotate and brings in the complete in the anterior chamber, and then remove with this simple verbectis without irrigation, and you can see without damaging you have to remove. And then vitrectomy is very, very important part in such type of cases. So you have to do the vitrectomy for better visualization, better to stain with the time slow acetate, and you have to make the incision 180 degree apart, because at that side you have to enclavate. So inject the air under air. This insert this iris claw lens and rotate it horizontally under air, so that then inject the viscoelastic substance. The slide on the one edge hold with this lens holder, and with the another side with the simple spatula or the Shinsky hook. Just you can see, just posteriorly push it, just enclavate the iris in the claw of the. You can see the very easy procedure. And repeat another side. You can see, just press slightly, just go behind. You can add the spatula. And then you can see how nicely you can see, just like you have implanted the IOL in the posteriorly, like in the bike. Now you can see this another case, as somebody operated and just came to me with this kind of presentation, in which this IOL is this posterior dislocated, though it present the mid vitreous, and the vitreous present in anterior chamber. Again, you can see, and then same procedure you can repeat it again. Again, vitrectomy is very, very important. The anterior chamber must be clear of any kind of any vitreous. Otherwise, it may lead to late complication, vitreous pull, etc. That may lose the detachment, macular edema, etc. So this is very important part of the surgery, especially if the posterior capsule is not there. And you can see at this side there is some synechia is present. Just with the help of this even bit a probe, you can just go all around. You can see, and then again you can just inject the pilocarpine and constrict the pupil before enclavating the posterior iris claw lens. Then rotate it, this iris claw lens horizontally where the site where you want to just enclavate, and then hold with this lens holding forceps, and then pass the Shinsky hook from side port, but both the sides should be at 180 degree apart. And then you can see slightly with the help of Shinsky hook, pull the iris and go behind it, behind the iris. And then the important, because you have to take slightly, slightly bring forward, so that it tint this haptic part. And then you can see how nicely in this condition you can implant. You can see the beauty of this surgery without any problem. Different cases, so it has wide scope. You can see any cases. I'm going to show later on in the next video some complicated cases also. So the rest of the procedure, just you can watch it. So it has great advantage. This iris claw lens is above the anterior chamber, even the scalp fixated. No need of any suture or suture related problems, and it is posteriorly placed at the anatomical position of the lens. So in the endothelial chance of endothelial damage is very, very less. And so it is, there is no any problem enclavation. And very easy procedure, very simple procedure, any kind of procedure. It takes hardly 1 to 2 minutes to enclavate the iris claw lens. You can see, watch again. This rotate horizontally. And the important thing you can watch, just go behind the iris and slightly, this is horizontal, slightly tilt it. If you tilt it, you can see the haptic side of the haptic, and this only you have to push like this. Suppose you enclavate it, just press it, then iris will be enclavated very easily. And this will be very simple method, and it gaining the popularity without any complication. Very nothing. I have not observed much complication. Sometime it is reported in the book the disc complication, but till date I have after so many cases I have not observed any kind of disc inclination of such kind of lenses. Then you can see how the beauty of this this kind of surgery. And again you can see this is another case. You can see, and this is this canuloplasty. You can see, and how much you can see how much people dilated, and this mechanically pull all around the iris and to assess whether this iris repair can be done to bring it the pupil is small. So I am just planning in this case open sky do her the purse instinct type of suturing, that is iris insert class. This 10-0 polypropylene suture you can pass all around the pupil and see how you can, even in these type of cases you can implant this posterior iris curve very well. Then pass all around. In the there is no capsule, so again have to do the betectomy. It should be clear up slightly, go posterior face should be go slightly little behind, then little bit tight it, and bring the don't tight at this stage, and then slightly constrict it, and then again you can see how you can bring this pupil a small appropriate size of this one. You can see again these conditions you can see in the open sky also how you can inclinate very easy. Other in such type cases in open sky it is very difficult to perform the square fixated lens. But this you can observe, you can see how simply and you can inclinate these lenses in such kind of conditions. You can see from go again from the side port, and you have to this inclinate periphery. The iris inclinated now again tight and then make the knot. You can see. So this is another case. You can see this is a case of partial anterior staphyloma. And then even this case, see what to do and how to do in such type of condition. You can see press it with ectasia is present. You can see, and then do this and see what happens. Just just do the capsulotomy, and after this lens comes. Sorry, because of bit test, so unfortunately bit test comes. But no problem. You can watch how to manage this. Now, in a certain stage, you have to manage it. The complications. You can see, ask the assistant to hold the iris and make it little bit stitch and then attend it. So you can implant. You can see even this. Ask the assistant to hold with the forceps, and simultaneously you can indent. You can see. Then you can repair the iris. You can see. Bring the iris and you can repair it. You can see, and then pupilloplasty can be done simultaneously also. That I would like to highlight that this retropupillary, this iris lens is useful in any kind of condition. It is very severe to all of us, all of you, even general ophthalmologist, anybody. You can see, and then with this stable lens is very much stable, and make then again this one suture. So I'm not showing the. You can pass from another side vertically, and you can see it is inclinated very well. Another last case, because everybody is hurry to go back to the home, but this is another interested case. You can see this I will drop posteriorly. You can just do the betectomy, and anybody can do, even anterior segment surgeon can do. This is very easy. Even this kind of I will drop and removal of this, anybody can learn. I am doing also the posterior segment is simple surgeries. You can see, bring it interiorly, and with before that you have to make the incision, ischocanal incision, and then hold the lens now, brings in the anterior chamber above the iris, and then hold the lens, and you can remove the lens very easily. And you can again go back and see whatsoever any kind of bit test stand, or if left, you can check it completely. Bit it is again very important, and you can see from make a side port 180-degree apart. And under this irrigation is on, so you can chamber should be maintained properly. You can insert the lens, and again just rotate horizontally, and from the side port that you have made, 180 degree, any direction, not necessarily 3 to 9 o'clock, you can implant at the site where the iris is present if iris is deficient. So again, hold with the help of this lens holding forceps and go again the same procedure. You can see any condition. I am just showing the number of cases because so only by observation you can see the use of this iris lenses, how easily perform, in how many different cases you can do. So this is a very simple technique and better technique if you are in the trouble, if there is no posterior capsule is deficient, then you can perform very well. You can see again, sir, how this pupil is well centered, dilated, centrally placed. You can see sorry. Thank you very much for this.
Thank you, Professor Singh. That was absolutely excellent and very, very, very elegant videos and very beautifully explained. If there are any questions from the audience for sir.
Are you using the flexible iris claw?
Flexis is a PMMA lens. Flexis is not available, though the future it may comes. But these are the PMMA lenses. This is very late. I have operated a number of cases, maybe 200 even more. They have not countless number of with them. I'm our hospital referral center. The patient coming from different surrounding district, states, other states also, MP. But very, very stable. I have not observed any single case of disinclination. These are number of, I have shown only few cases. That I have a lot of series of different this case. So this is very, very simple, very easy and very stable. Very good. Such type of anybody, with any hand complication, it may happen with anybody, at least the youngster it happen, even the expert hand, or in the patient condition itself. Sometimes, Sweden syndrome is there, subluxated, Marfan syndrome, though I have even Marfan syndrome, I have just placed the lens in the bag. After this subluxated by pulling different, that is another subject. But the different situation you may end up in any condition. Trauma, in trauma cases, earlier I have shown the traumatic dislocation, posterior dislocation, traumatic dislocation on the PCI well. You may have any. So in this, at least everybody should know. If there is posterior deficient, what to do? Then you should be in confidence enough. Then you can manage any kind of complication problem very easily, very nicely. And without taking much time, even a open sky you can implant very well. Very difficult to implant the ASK fixator lenses. So that's why I have done the series only video. That is the reason I have done.
The procedure is
very simple. Only only just in case I would like to 1 minute. I will.
Yes, sir. The only issue is that you should have a confidence that it is going to stay there.
Yeah.
So
this
one
is the
thing, I
main
would like to
concern,
show
sir.
one thing, how to enclavate. How to enclavate. This is very important part, how to enclavate, First, suppose this is the iris here, and you have placed this behind the iris, like this. I'm going to just rotate in front. So this is the lens. What to do? This is the rather tics. Just slightly, this is the iris plane, and this is the posterior iris plane. Slightly like this. If you tilt it, what will happen? You can see this claw. The claw very big. You can just tilt it, you can see the claw. Once you claw at the side, you can then what to do? Only just place the sensitive hook at this claw, and only small closer posteriorly, like you can this much, and you can feel if there is whether this enclavated or not. So it gives little bit of sound, like you have some side of a sound or a small tick like this. If you click, see this kind of, just how what you can see. This kind of even, and you can feel in your hand. That is enclavated variable. If you do two or three cases, if you very confident, you can see, just put it. It gives little bit some sound, at least some friction like this, like this. Yes. If have any doubt, that's I'm telling. If I'm telling this is experience, you can from just one watching, you can observe this is very well enclavated. If you have doubt, pull it, see if the problem, again go, I repeat.
So what about the biometry calculation in such cases?
Biometric calculation, it is placed slightly anteriorly. So in the normal PCI, you can reduce the number by one doctor. No, you have to be very gentle. No, I have to, this is one case open. I have even the in another my series of talk. I have this people class I have been done in normal cases, in closed chamber also. Different techniques. This is a insert class technique in the form of persisting suture. Just I am trying to innovate further the needle and suture that are, but from outside by three port, even the this closed chamber, you can anybody can do the insert class from outside, but you have to make different ports. I have the video in some other presentation. So this very you have to little bit very gentle. Otherwise, definitely it may, but you can see it can be you can do.
Which suture, sir? Yeah.
Polypropylene suture.
Proline. 10-0 proline.
Not
yes.
nylon, not the nylon.
Yeah, and
it's irritable to the iris.
In fact, these lenses can be put in oblique position also.
Yes, not necessarily. I have already told that if the
wherever tissue is available, I think so.
We have been using these lenses as the posterior and as the increasing enclaved lenses. The posteriorly enclaved lenses came later on. So this is a long. We have a student of Dr. Daljit Singh actually.
Then this I know he enclavated internally, but now his other person or his family member has enclavated
They come in
posteriorly.
small sizes also for children.
Different sizes are available, but it is not small sizes have little bit much problem. What is the problem? If you implant a smaller smaller in the way in the form of optics or in the form of haptic overall. If you both have disadvantages. If you implant the smaller size of optics, what will happen? If people dilate, what if the as glare is maybe there, you may feel a problem. So you have to at least 6 mm.
He put it in microcornea also.
Yes, different. You are right. In the microcornea, you can choose. So there is a variable size of lenses available. In the small, you can use even. You are right. Even the smaller you can use this iris class is very well. It's better than other lenses. Other companies not making smaller lenses, but the iris class is available in the different sizes. But and overall size is also very important. Overall size, why it is important? If smaller size, what happen? Pupil, in the periphery, pupil is not mobile, and it is chamber is shallow. Not mobile. So if you have to include not in the mid periphery, you have to include periphery. If you include periphery, lens will be very much stable. But if you include mid periphery, it will with the iris movement it will smooth, fluctuating like this. So this is the important.
And sir, do you do a iridectomy? Sorry for interrupt. Do you do a peripheral iridectomy or do you recommend?
Now this lens is not exactly plano.
Okay.
It is angulated lens. I have not done with this iridectomy, and there's no advice opinion. Like in the fixed surgery implantic, there's no need. Similarly, there's no need.
Especially if you have done an anterior vitrectomy, then it's not required.
This lens
Yes.
is available in this part, so it is just behind the iris. No problem.
So which company lens are you using?
Different companies, Optima and some other different companies available.
There are a lot of
Very
companies now marketing it, sir. I saw it.
Huh?
There are a lot of companies. There are 3-4 companies.
Lot of different companies coming one by one. Is company very easy.
So it comes for around 800 to 1,000 rupees, something like that.
Not very costly. Not very costly. Just like the cost is just like a PMMA lens. That's all. The cost is same. Maybe the company may charge with the name of this company much more, but this price is as equal to the any PMM lens. PMM lens is somebody is marketing 100, somebody is 1,000, 2,000, different story. Earlier, in the when the era came, they are marketing 2,000, 4,000 like this.
To us, Dr. Daljit Singh used to fly free of cost.
Huh? What?
Dr. Daljit Singh used to fly us free of cost.
Yeah.
But now they are available at 600 rupees. Yesterday only available.
Even 600, even less than 600.
Company, I have forgotten the name.
600, but I know some of the company market only 400 something, 400, 500, 300. Cost is no problem. Cost very cost effective. Very cost effective. No need of any suture or time taken. Or procedure is very simple. You know, scalp fixation. There is lot of development of technique of suturing, glue, doing the glue, and how to shake hand technique. This way, how to pass it, how to. But it's so easy. You can only if you know the basic principle that I have told. Slightly like this, tilt it, and you can see the clock. Very you can from interior, and just like this, put it. The silk hook will be better. Silk hook, just like this.
Thank you so much. Thank you so much, Professor Singh. That was absolutely amazing, and I'm sure everybody has learnt a lot. So with that, I think I'd like to conclude the session. Thank you all for participating, and thank you also, Dr. Prasad. Have a safe trip back home. Yes, safe trip back home to all of you. Thank you.